ask you only
Yes.
that would you want a detailed one or a simpler one, the physiology?
So we'll go with the detailed one. If needed, we'll go with 2 sessions. But I want all the fellows, all the doctors, all the clinicians who are sparing their time uh, to have a fair understanding, because most of us, we spend a lot of time in managing cases, but sometime we forget that most important aspects are not understood well. So it's a request, if we can manage in 2 sessions, then also it's okay. But detail will be better, sir.
Okay. So I'll try to cover the ICU related physiology today, and basically you should know about the ICU physiology also, because many times you will be fixed with a pediatrician or fixed with the intensivist, and your pneumonia case might be stuck in ICU. And after this physiology lecture, we don't want these type of reactions, because physiology is boring, but definitely it is essential. And we want that you understand physiology and its practical applications. I'm not going to go into the gases, equations, not that type of physiology. What is applicable in day-to-day practice? So if you can see the evolution of ventilation, it has gone from these iron lung ventilators to newer ventilators, which have all these buttons. It is something like the mobile phones. But remember, it's only few buttons in mobile phones that you use, and we'll keep to that particular buttons only. We are not here to discuss too many things. So can they answer, Nitin, or they'll be silent only? Uh, okay. So how do you normally breathe? So do you have a pressure breaths, or do you have a volume breaths? So imagine that this type of flow is happening in your lungs. So usually once you breathe, it is like a running. The negative intrapleural pressure increases. When you're sleeping, the negative intrapleural pressure decreases. So it's very important you understand that our breaths are not a constant flow, but they are decelerating flow like this. They resemble the sine wave, which is normal breaths. That is a decelerating flow. It goes top and then it comes down. So initially, in the first millisecond of the inspiration, our alveoli are filled immediately. So we normal physiological breath is more towards a pressure breath kind of mode of ventilation, normal. Though if you read the book, they'll say it's sine wave. And expiration, whether you apply a volume mode or you apply a pressure mode, will be mostly passive. So if you see this type of flow and time scalar in your ventilator, the first breaths will be the constant flow and this will be the decelerating flow. Now, this is very important that many times pediatricians or intensivists will say that we'll put the pressure mode, somebody will say we'll put the volume mode. So you should understand what are the problems that are there once you apply these type of modes. So what is physiological is definitely a pressure mode, and this is how it appears in the flow time scalar on your ventilators. So this is a pressure ventilation, decelerating flow, and this is a constant flow that happens in a volume mode. Now, advantage of this is all the alveoli within the first milliseconds, even in the periphery, get air rapidly. That is, if you're watering a garden, so if you press the hose of the water pipe, the water will go towards the periphery of the garden also. So that is your pressure breaths. So there are many advantages of pressure breaths. Uh, Second, this diagram you would have seen everywhere. So what keeps your lung open? That is a basic question. And I would really like if some people could answer this. So is it the vocal cord that keeps your lung open, or lung has a tendency to collapse inwards? Uh, Nitin, can they answer or they are all muted?
Sir, they will not reply and as a question, but they will put it in the chat box.
Chat box, correct. So my basic question is, in normal physiological state, like without ventilation, what keeps the lung open? Anybody would like to answer in the chat box? Open the chat box. They're saying surfactant. Okay, surfactant, we'll come to surfactant later. It is basically surfactants for hysteresis. Now, hysteresis is something that will come later. So in a normal lung, like your lung and my lung, what keeps the lung open? So there's a pressure difference. Okay. Okay, good. So I'll try to be more specific. I'll try to be more specific. So in a normal resting state, there is no negative interpleural pressure. FRC. Okay, FRC. So why is this FRC happening? My question is that why doesn't the lung totally collapse? Like if you see over here, it doesn't totally collapse. Why is the FRC being maintained? So he's saying the outward coil of the lung and the inward collapse of chest wall. Okay, so we are getting a good variation of answers. It's nice to have these inputs. Now I'll ask you, suppose if you cut a goat's chest in the center, the chest wall, the thoracic cage, will it collapse inwards or will it go outwards? I'm going a little practical. Perfect. Perfect. So people who have seen the butcher shops, if you go and cut the chest wall, the thoracic cavity has the inherent capability to move outwards, whereas a lung has an inherent capacity to always collapse. And it is the opposition of these two forces, the thoracic wall going outwards and the lung going inwards, the pressure that is maintained between this, it prevents the chest wall collapse and maintains the FRC. Am I clear now? So the lung has a tendency to go in and the chest wall has a tendency to go out, and they negate each other, and that's why the lung doesn't collapse. Whereas in infants or neonates, the chest wall is cartilaginous. The lung exerts the pressure because of inward pulling pressure, and the chest wall in neonates collapse. Whereas adults, it's very difficult. And suppose there's some obstruction upward, like a stridor or a laryngomalacia, these children will ultimately develop a pigeon shaped type, excavated type of chest wall, a deformity that will happen because of these physiological effects that take place. Let's going ahead. Okay, now there's a question on the screen. Which one do you think is more elastic? Is it the steel or is it the rubber? Let us see what people answer. Which is more elastic, rubber or steel? Okay. So many people are saying rubber. Now, what is elasticity? I will try to keep it very simple. I'll not go into details of it, but anything which comes back to its original shape very fast after removal of the external force, that is elasticity. So if you take a steel plate, and in steel plate, if you try to deform it, it will immediately come back. So steel is very elastic, whereas rubber, if you do it, it will come back to a lengthy state, and then it will come back slowly to its original state after some minutes. So rubber is less elastic, whereas steel is more elastic. Now, what is compliance? What's the relationship between compliance and elasticity? Anyone? Relationship between compliance and elasticity. So compliance is usually inverse of elasticity. So if steel is very elastic, that means it is less compliant. That means I will not be able to change it much. Whereas rubber, which is less elastic, is more compliant. Now, why this is important? You have to understand the lung is very compliant. That means when I give some pressure to it, the volume changes rapidly. It is very compliant, but it is not elastic. Whereas the same lung, if it becomes consolidated, then it becomes less compliant, but more elastic. Hope I'm a little clear uh, in my messages. So you have to understand that lung is compliant, but less elastic, like a rubber. But steel, on the other hand, is very elastic, but less compliant. So how do you normally breathe? The control of respiration is definitely, if you can see over here, there's a trigger which starts in the brain that initiates it. The trigger can be your CO2 retention, or it can be your normal excess or hypoxemia. Multiple triggers are there, or respiratory centers. Then what is the limit? Limit can be the stretch receptors in the lung. They tell you do not cross this particular limit. And if they're crossed, then the cycle ends. So even every respiration in the body has a trigger, limit, and cycle. Trigger is what initiates, limit is what it limits. It doesn't cycle it, it just keeps it going for that particular moment, plateaus it or limits it, and cycle. Now what the simile of cycle would be like a pressure cooker ki CT. So when the pressure builds up, and then the pressure cooker just pops off, the valve pops off, that is a cycle happens. So you have to understand the difference between the limit and a cycle. So this type of physiology, everybody would give you in books also. So you have to understand there is a airway pressure, which is there at the mouths. Then there is a conducting airway. Then there is a airway which takes part in respiration. And then there's a alveolar pressure. Now, the difference between the alveolar pressure and the airway pressure, even the difference of -and +1 will would start the air to go in. And also, if it is more +1, it would push the air out. You have to understand that this is very important. Then there is something called as a pleural pressure, which can vary from -3 to -10. So when it goes more negative, then this alveolar pressure will become negative and the air would come in. And there's pressure at the body surface. Why this is important? Obesity, and sometimes there's a lot of tissue edema. So you should understand this pressure at body surface also contributes or is uh, a resistance that basically airway or air gas has to go through so as to reach the alveoli. So the difference between the pressure at the airway opening and the alveolar pressure is called the trans-respiratory pressure. Whereas the difference between the alveolar and the pleural pressure is called the transpulmonary pressure. This transpulmonary pressure is very important so as to maintain the alveolar inflation and volume. Now, this is the pressure that we mostly talk about in our ventilation, in all physiology. That is a transpulmonary pressure, which is required to keep the alveoli inflated. If the transpulmonary pressure goes beyond a particular limit, the alveoli will break down and will cause pneumothorax. Whereas the trans-respiratory pressure is just the pressure required for the gas to start going in or coming out from the lungs. Then there is something called as a transthoracic, which is more important when there is obesity or there is some amount of significant edema. This is the pressure which is needed to expand the chest wall, in addition of the lung also. Okay, so if you see, these terms are very differently defined in various textbooks and it has created lot of confusion. So what I have told you is very simple. Remember that different textbooks give different combinations and permutations and they try to confuse you. So let us start at the end of expiration. At the end of expiration, like the gas has gone out, the pleural pressure is -4. Over here, now there is no gas exchange taking place. So the alveolar pressure is 0 and airway opening pressure is also 0. So the trans-respiratory pressure is 0 at the end of expiration. Over here, if you see the transpulmonary pressure would be the alveolar, which is 0, minus the pleural, which is 4. So transpulmonary pressure is 4. And the transthoracic, similarly, on the other side would be -4. So if you see this 4 and -4, they go on the opposite side and they keep the chest wall open, the lungs open. They don't allow the lungs to collapse. Now you see the mid inspiration. What happens when we start taking in the breaths? That means diaphragm has gone down and the pleural pressure has gone up from -4 to -5 now. It is mid inspiration. So over here, definitely the alveolar pressure, because it is -5, it has become -1 now. So trans-respiratory pressure is -1. The gas starts happening. The transpulmonary mid inspiration would still remain 4. Because here the pleural pressure -5 got converted into -1 over here in the alveolar. This allowed the gas to come in. And we'll forget the transthoracic now. Now let us go to end inspiration. That means lot of pleural pressure has gone in, -7. Over here again, because now the alveoli are fully distended, they cannot take in more air. The transalveolar pressure, trans-respiratory is 0, alveolar is 0. Over here, the transpulmonary becomes +7. Now, this is a spontaneously breathing patient we are talking about, not on mechanical ventilation. Now we start exhalation. Over here, now the alveolar pressure becomes +1. It's a phenomena where the lung, which is now fully, chest wall fully expanded, now is coming down. So it is exerting the pressure on the alveolus, creating a +1 of alveolar pressure, whereas the airway pressure is 0. So air will start going out, trans-respiratory is +1, whereas the transpulmonary mid expiration again becomes 4 only. Now this transpulmonary is just alveolar distension. It doesn't mean more than that. Hopefully, you're now clear with the terms, the trans-respiratory, transpulmonary, and transthoracic. Practical importance in pediatric critical care would be transpulmonary, whereas if you're discussing your OPD pulmonology practice and your obstructive sleep apnea, then transthoracic will also come into play. Now the pleural space. Now, if inside the pleural space, there is some fluid collection, then the pressure difference will change again. Now it is putting the pressure on the residual lung and the alveoli. Or it can be both sides pleural effusion, or it can be pneumothorax. This also will cause the residual lung to collapse because of this extra pressure in the pleura, which is not accounted for. Whether it is filled with fluid or air, it will result in extra pressure, which will collapse the underlying lung. This is very simple. Now let us come to resistance. So, okay. So whenever there is a pipe, so the gas flow will take place from one side to the other end. So the diameter of the pipe is very important. The wider the diameter, more easier would be the flow. So radius is very, very important once you're discussing resistance. So the flow that is happening from higher pressure to the lower pressure would be the driving pressure when we are discussing physiology. This is different from the driving pressure of a ventilator. So the practical significance is, if you're putting an endotracheal tube, the shorter length of the tubing and the wider radius will make the pressure within the system less. Also, the wider tube would make the flow more laminar. As the tubes go shorter and shorter, the flows will become turbulent. Okay. So now let us compare the first photo, which is shown over here, versus this photo, which is shown over here. So what do you think is happening over here? Anybody in the chat box can reply. So definitely the resistance has fallen. So now the pressure which is required to deliver the gas in this lengthier tube and the shorter tube will be much higher as compared to the first diagram. So this will be a high resistance tube and we need to give in larger P1 for the flow to go down to P2. So the answer is small size ET tubes and longer endotracheal tubes are preferred in your daily practice. Also, when the tube gets blocked, it will cause high pressure alarms in the ventilator. Now let us look at from the other way. So which disease do we talk about which has high resistance? Which pediatric disease has high resistance in the airway, even in OPD practice? Asthma. So in asthma, why do you think it's a wheeze that we most commonly seen? No, pneumonia is not airway. Pneumonia is a parenchymal disease. Asthma is a airway disease. But wheeze is most commonly seen in expiration, not in inspiration. Anybody can answer why? So to answer it, so once you, everybody now take a deep breaths. So once you're taking a deep breaths, there's a tendency of the airway to expand because of the negative interpleural pressure. Now, when there's a negative interpleural pressure, there's a tendency for the airway to expand. So you won't hear a wheeze when in inspiration. But in expiration, the airways collapse faster, and that's why we hear a wheeze or a whistle. So therefore, asthma, though can happen in inspiration also, but is predominantly a expiratory disease. Now, if you see over here, the resistance, which was 1 centimeter, was here in the bigger tube. Now it has shorter down by only 0.5 centimeters, by 50%. So decrease in resistance by 50%. The amount of pressure required to empty this alveoli is 16, whereas it is only 1 in a normal person. So the asthmatic patient has to generate lots of pressure because the equation is pressure is inversely related to 4 times the resistance. So smaller the resistance, more the pressure is needed. And the child has to exert long across a long expiratory time, which produces a musical sound wheeze. That is why it's very important when we are treating asthma, we have to keep longer E times, expiratory times in your ventilator, and you have to keep on giving bronchodilators so as to decrease or increase the radius of the tube. Hope I'm clear. I'm going very slow and trying to be as simple as possible. Okay. Now there's something called as turbulent flow. You would have seen in your practice many times pediatricians, they give some sedative for a patient who is struggling a lot in breathing. So what does that sedation do is it converts the turbulent flow into a laminar flow. So whenever there is already a small airways in children and it's full of mucosal edema or a spasm that is happening because of either bronchiolitis or plugs, whatever the reason, the resistance falls down and the child cries. The more pressure the difference, the airflow becomes turbulent. So what we try to do at that point is we sedate the child so that the cry disappears and it converts the flow into a laminar flow, and laminar flow has less resistance along the airway. So therefore, turbulent flows are not liked by anybody in pediatrics. We prefer the laminar flow. Now, once we go from top to bottom, from the trachea to the various alveoli, bronchioles, will the resistance increase because the tube size decreases, or will the resistance decrease? Will it increase or will it decrease? Please mention in the chat box. When you go from trachea to the various bronchioles, terminal bronchioles, and alveoli, do you feel, because of the smaller resistance of the ET tube, the resistance is going to increase or decrease? So somebody saying increase, some increase. Now somebody saying decrease. So we understand it's a democratic country, but its physiology is the same for everybody. So both answers are right. Let us understand what is the trick behind it. So once you go from top to bottom, the nose, mouth, large airways, they more have a turbulent flow and contribute 80% of the resistance. Whereas the same airflow, when it reaches down, because it keeps on branching, the airflow actually decreases. The flow of the air decreases, it converts into a laminar flow. And because now you can see, because it's branching, the total cross-sectional area has actually increased of the total lung. So because there's a decrease in velocity, increase in the area, and becomes more laminar as it goes down. So resistance of the lower airways is only 20%. It is not as we suspect that it should increase when it goes down. Hope I'm clear in this. Okay. So this is what the graph is showing. Set up to a particular level, to the level of the 8th or 9th bronchioles, it keeps on increasing. After that, because the total surface area increases and the velocity decreases and becomes more laminar, the resistance actually comes down. The resistance actually comes down. So if you see the various charts that are there, so this is the between the 5th and the 16th bronchiole, the resistance, there's a big fall that happens. So if you see, the resistance keeps on increasing 800, 750, 1500, 1700, and then it falls at the level between the 5th and the 16th bronchiole. And then it keeps on falling, it goes up to 18. So the lower airways do not contribute to resistance because of the phenomena of increased surface area, decreased velocity, and it becomes more laminar. So this is a paradox. Hope everybody has understood this point also. Now, again, once you're discussing physiology and we don't discuss this, it becomes very difficult. So everybody, if I say what is FRC, so everybody will write functional residual capacity. So why is FRC important? If anybody can tell that. Why do you think FRC is important? So the difference, what is FRC is a capacity. It's a combination of two volumes. So what are the two volumes? It's a combination of ERV and RV, expiratory reserve volume and residual volume. So it's a combination of ERV and RV, that is FRC. Now the importance of FRC is, so which is easily diffusible, oxygen or CO2? Again, open for the house to answer. Okay, so mostly CO2 goes much easier and rapidly. Let us ask me one more question. Do you think that gas exchange takes place in expiration also, or it only takes place in inspiration? Gas exchange happens in expiration also, or it is purely a inspiratory phenomena. Gas exchange means O2 and CO2 going from from the alveoli to the blood and CO2 coming from the blood to the alveoli. So we have to understand that even this ERV contributes to gas exchange, and this RV also contributes to gas exchange. It is definitely mostly an inspiratory phenomena, agreed. But once you're against a wall, we have to exchange, we have to understand a collapsed alveoli will have no benefit in gas exchange versus a minimally distended alveoli, which will de decrease the CO2 also. Even in expiration, the CO2 change will take place. And because this alveoli is now opened as against to a closed alveoli, the compliance will actually improve. So this is particularly talking about in ARDS. So when we are discussing ARDS, we have to maintain FRC. When FRC is maintained by giving your PEEP, the alveoli which were initially collapsed are now opened, and even in expiration, the gas exchange takes place and improves the compliance. So improvement of compliance can be judged by mostly two parameters. The first parameter, clinically judgment, is the O2 should improve, and the second parameter is the CO2 also should fall. If CO2 is also falling and O2 is improving, that means you have achieved some target in compliance. Compliance is delta V by delta P. So only when little amount of change in pressure improves a large change in volume will have both effects. So if only oxygenation is improving, but CO2 is not falling, that means compliance is actually not improving. It is becoming bad. So that is why FRC is important. Why everybody is harping on FRC is because gas exchange takes place in exhalation too. Okay. So regarding this, infants have low FRC because the chest wall actually tries to collapse inwards. So we need to give them more CPAP as compared to adults. Okay. Now there is something called as collapsing capacity. Also, we'll come to that also. Okay. So if you see this compliance is delta V by delta P. So small change in pressure, like from here to here, if the pressure is increased, there's a big change in volume. So this is a normal lung, which is compliant. Whereas the top part represents the asthmatic lung, whereas it is where it is totally inflated. Whereas the bottom part represents an ARDS lung or a collapsed lung. Now over here, the compliance is very low. Now it has improved over here, whereas again in the top, it's an asthmatic lung. If we put in more pressure over here, the volume change will not happen because it's already distended. The pressure will only keep on rising. So therefore, asthma and ARDS are opposite sides of a coin. Here we require to give in more pressure. Over here we require to give more expiratory time and less of PEEP in asthma. Hope you have understood the difference between the two range. And our target is this steep curve, that is a normal compliance. Now there is something called as closing volume. Now forget whatever is written there. So you have to understand in children, the small infants and neonates, the chest wall is cartilaginous. Because the chest wall is cartilaginous, there will be a airway collapse which will happen faster, not in adults in comparison to adults, but airway collapse will happen faster because the chest wall is collapsing. And because of this airway collapse which is happening in infants, there will be some amount of extra air that gets trapped in the alveoli, which is not counted in the FRC, but it is above the FRC. That is the closing volume in infants above the FRC. And the closing capacity in infants become more than the FRC. because of this chest wall compliance, which makes the airway collapse faster. Whereas in adults, the FRC is more than the closing capacity and closing volume is below the ERV. Again, why it is important? The only thing is we have to give PEEP, otherwise to keep the airway open so that this trapped air which is beyond the collapsed airway can come out. The only way we can open this is from an external PEEP. So this is what we are trying to say. The closing capacity is more than the FRC in case of neonates, whereas in case of adults, the FRC is more than the closing capacity. Okay, then there's something called as the time constants. Now, what is time constant? It is something called as a compliance into resistance. So there are two parts which are important so as to keep the lung either inflated or deflated. Compliance means mostly inflation में and resistance will be mostly in expiratory phenomena as far as a normal physiology is concerned. Let's forget this, what it means. Let us focus on what is a practical application. So if you see the time which is required to fill a particular lung region to 90% of its potential capacity is your time constant. So one time constant is required for 63% over here, three time constants for 95%, and five time constant is required for filling both the parts of the alveoli to 99%. So in ARDS, you need to give in more TI for the alveoli to get filled. Whereas, let us not talk about asthma. In asthma, you need to give in more TE for the alveoli to collapse, or so that we give in more time for the air which is trapped in the alveoli to come out. So that is the importance of time constant. So we require time constants both in case of a stiff lung as well as in the case of a resistive airway. Skip this. Okay. Now there's something called as a pulmonary vascular resistance also, the PVR. That also contributes to gas exchange, and it is very important because these capillaries which are there in between the alveoli and over the alveoli also is important for gas exchange to take place. So if we have a lung like an asthmatic or an ARDS, the PVR would be higher in both. And how does it contribute to gas exchange? Let us see in this diagram. Now these are the alveoli. See over here, the top one, this is the alveoli. And over here, these are the alveolar vessels. So when this is inflated, the alveolar vessel collapses. Whereas there is a vessel, corner vessel, which is in between the two alveolar balloons. So once these two balloons are inflated, if you see, if you inflate three balloons, you will see a in-between space will always remain free. Now here the blood flow will be good. Whereas these blood flow which are in between the two alveoli will get collapsed. Okay. Now let us see this type of setting when these alveoli are totally collapsed. So the vessel which is in between the two alveoli will open, whereas the vessel which is in between these four, because of the collapse and the traction over here, this corner vessel will get collapsed. So neither this takes, because this is getting compressed, this is not taking part in gas exchange. And because this collapsed now, this is not taking part in gas exchange. What would be ideal is these also remain open, the alveolar vessels and the corner vessels, they also remain open. If both are open, then the VQ, ventilation and perfusion matching will happen. But if one is collapsed or this is collapsed, the VQ matching will not happen. And this happens at FRC. If you over distend or give higher PEEP, then this will happen. If you give low PEEP, this will happen. At optimal PEEP, this will give the optimal VQ matching. Now there is something called as the lungs, zones with inside the lung. So if you see over here, this is a heart, which is a pump. So the lower part of the heart, which is near the pump, if we are standing erect, so which is near the pump, will get good perfusion, whereas the top or the apical part will get less perfusion. Whereas the top of the lung during standing will get good ventilation because the alveoli over here are fully expanded, whereas the alveoli which are at the bottom of the lung are collapsed because of the pressure given by the top of lung. So these alveoli will be collapsed over here, whereas these alveoli will be fully ventilated. Now these alveoli which are fully ventilated have less perfusion, whereas these alveoli which are collapsed are having good perfusion. So there are three zones which are there in the lung, which is called as a West zone. So if we see, these are the three alveoli, and we have three pressures: arterial pressure, alveolar pressure, and the venous pressure. Now let us divide into three parts. The zone 1 is a well ventilated alveoli, which is there in the apex, which has less perfusion. So if you see, the perfusion is less, but there's a lot of air over here. So what is this space called as? Is it a shunt or is it dead space? You can write in the chat box. This is a normal lung we are talking about. So in the normal lung, the top of the lung has an alveoli which is filled with gas, but the perfusion is not happening. That's a dead space. So this does not contribute much to the VQ. Now let us go to the second part, zone 2. This is a good zone where the arterial pressure is more than the alveolar, more than the venous, and there is a good amount of gas and the good amount of perfusion happening here. Now let us go to zone 3. Zone 3 is the one where there is a lot of perfusion, but the alveoli aren't collapsed over here. So from the center, if you see, this from the center of the blood vessel, this will not take part in gas exchange, the center of the blood vessel. So what is this space called as? Is it a shunt or dead space? So there's too much perfusion over here, and this from the center, it is not taking part in gas exchange. So even if there is some gas over here, it will not take part because the center is going. So this is a shunt. So within a normal lung also, you have a dead space, you have a shunt. You have this. In a pathological state, it becomes quite obvious. So this is how you basically divide the lung into three zones. We call it a zone 1 and 2 and 3. Now, if suppose in this particular zone, which is collapsed, I apply some PEEP, PEEP. So this will convert this zone into zone 3 into zone 2. Now, this is just to give you an example. Now, this was a shunt which is happening, alveolar collapsed. So the center of the is not taking part in gas exchange. The blood flow is just going from left to right and not taking part, not coming in contact with alveoli. So what we do, we apply the PEEP. So when we apply the PEEP, now almost all the blood is coming in contact with the alveoli. But if we keep on giving extra PEEP, this will further collapse and it will convert the zone into zone 1. So excess PEEP also can be detrimental and can convert a shunt into a dead space. Okay. Now there's something called as the heart-lung concept. You have to understand that the heart is also within the thoracic cavity and it is exposed to changes which are happening in the lung. So if there is a negative interpleural pressure, it will have a different effect on the heart. Whereas if you give a positive pressure ventilation, like happens in a ventilator, then it will have a different change in the heart. So a little bit about the VQ also we'll discuss. So ideal will be VQ is 1. That is the ideal. It's not always perfect. There are bronchial vessels which are taking place. So some 5 to 10% will always be happening. It will never be 1. It will be somewhere less than that. So some amount of shunt will take place. Now let us see this. Now this is the trachea and these are the alveoli. Now the first part is this is blocked over here and the perfusion and this is open over here. So there's large amount of air going here, but none going here. And here also it is going. So over here, there's good perfusion, but no ventilation. So what is it? It's a dead space or shunt. Good perfusion, no ventilation. You can write in the chat box. What do you think it is? Correct. So a shunt is happening. That means what perfusion is there, but it's not coming in contact with oxygen. So even if I give 100% FiO2 over here or 200%, 300% FiO2 over here, it won't affect this. So shunt will not be affected by my FiO2. So this is important to understand. Okay. Whereas now we have this phenomena over here. We are giving lot of air, but perfusion is less. Then this becomes a dead space. So here over here VQ is less than 1. This is 1 is optimal and this is more than 1 is dead space. So you have to see in every lung there will be a shunt and a dead space and it will guide you whether you have to give extra PEEP, optimal PEEP, low PEEP, any effect of PEEP at all. Will it really change anything? Cyanotic heart disease. It's just to give you an overall idea that if you understand this physiology, you will be able to decipher what is wrong with the patient. Okay. So if you see over here, this mostly shunt that is happening, and this is dead space of an asthma that is happening. We know the type 1 and type 2 respiratory failures. We'll not go into the theory part. There is no significance whatsoever. So how do we keep the lungs open? So we have to reduce the VQ mismatch and get it close to FRC, because at FRC, I told you, both the alveolar and the corner vessels will be opened significantly for the gas exchange to take place. So here is the concept of your PV loops and the PV relationship. Now this would have been described in various textbooks and you would have learned also the pressure and the volume. So just to give you a fair part, so this is the inspiratory loop. It goes up, reaches a point, and then the expiration starts. Now there's a point over here called as a lower inflection point where a change in the pressure causes significant change in volume. That means it has started the steep part of the PV loop. And the upper inflection point is where increase in pressure is not causing a change in any further volume. That means you have hyperextended the lungs. It cannot go beyond that. So there's an upper inflection point. This is purely a theoretical concept. It has no practical application whatever. You cannot do it bedside. You cannot calculate your lower inflection points and upper inflection points. But definitely you can see these points in PV loops in your ventilator. They will give you an idea of what is happening, the graph shape, but you will not be able to contact or pinpoint those points. And then the expiration starts and it goes down. Now, what is hysteresis? That is the very important question. So here the PEEP will open this So you have to keep the PEEP above the lower inflection point. And if you go beyond the PIP, it can cause damage to the lungs. So this is just theoretical discussion. We'll just skip this. It falls down. So concept of hysteresis. Now, anybody can tell me what is hysteresis? Anybody? I want a practical definition and its practical application. Anyone, what is hysteresis? And we know it's due to surfactant. Okay. So if you see the PV loop, now look at the PV loop. Now let us take this cutoff point. This cutoff point at the pressure. Now imagine this is pressure of say 12. At this 12 pressure, the volume in the inspiration is this much. Whereas in the expiration, the volume is this much. That means there is more volume in expiration than in inspiration. So more gas exchange will happen in expiration than in inspiration. And this is because of surfactant. If surfactant is not there, we will lose this hysteresis, and inspiration and expiration will join together. Because surfactant is not there, we give the PEEP so that gas exchange takes place in expiration also. So HFOV and APRV work on expiratory limb of the PV loop, whereas the conventional ventilation works on the inspiratory part of the loop. This is not great, the inspiratory part. Much of the gas exchange, because the volume is more in expiration, takes place in expiration also. Hope you have understood the practical application of hysteresis. Because surfactant is not there, we have to give a PEEP. Because of the PEEP, the gas exchange will not take place. And that's why PEEP is very important. So at the same pressure in the curve, there's more volume in expiration and more chance of gas exchange. Therefore lies the importance of PEEP. That is the practical application of hysteresis. Now this is the so somebody's asking, maybe it's recorded, you can hear it again. Or I'll share the number. We'll discuss it again. Now there's a ventilator over here, and these are the ventilator circuit, then the endotracheal tube, then the trachea, then the alveoli. Then the bronchioles. So they are asking again and again. So adding PEEP will make the gas exchange possible or not? Definitely. So when the PEEP is given, gas exchange will take place. If PEEP is not there and surfactant is not there, the alveoli are collapsed. A collapsed alveoli is of no use at all. Whereas if you give some PEEP, that collapsed alveoli will take part in gas exchange. That is the whole point of giving PEEP, especially in neonates also. But we are not discussing neonates, we will discuss pediatrics. Okay, so this amount of, so the ventilator has to give in so much amount of, if you have seen, whenever you switch on a ventilator, you see the ventilator will give large volumes of gas. It will go large volumes, because it has to bypass the resistance of the ventilator circuit. It has to the gas has to bypass the resistance of the endotracheal tube, then of the trachea, then of the chest wall also, and the cosmetic edema. So a ventilator has to do lots of work so as to make the gas reach the alveoli. So it has to work against the chest wall, the pressure are lost in the tubing, it has to work against the resistance, and then it has to work against the recoil of the lung also, and also the transthoracic pressure. So all these pressures will be the pressure which is reflected in the peak pressure. But peak pressure does not mean it will cause a pneumothorax. What will cause a pneumothorax is the pressure at the alveoli. So, so we'll, okay. So we'll take this in the next session. So the summary, if you want to ask questions, you can keep on asking questions also. So we were going to the plateau pressure now, and we were going to discuss how it affects the uh, your interpretation. So it's not the PWEP which causes a pneumothorax. You have to understand it is the total plateau pressure which causes a pneumothorax. Do not be afraid of PWEP. PWEP will open the lung, will give the FRC, will help in giving some amount of hysteresis. And the resistance is mostly on the top of the airway, not on the bronchiole side. So for the top of the airway, in addition to giving CPAP, sometimes giving some sedation will convert the turbulent flow into a laminar flow, and which will be beneficial, especially in bronchiolitis. But be very careful when you sedate the child, it can convert into oh, a respiratory failure also. So how does sildenafil help in ARDS? So it's uh, so instead of sildenafil, if you can say INO, it would be better. Uh, so how does it help? We can talk this in the next class. Basically, something to do with the PVRs, vascular resistance. Basically, same at we can discuss this in the next class. You're all going towards practical applications. So it's important to understand the physiology first and then go towards the practical application. Nitin, is it okay?
Yes, sir, absolutely. Actually, I believe the first aspect of understanding physiology is that's why more important, because most of the questions will be taken for the pathology part, but if physiology is less understood, it becomes more difficult to resolve the ongoing pathological processes. There will be many questions. I think I will be sharing the talk with everyone so that they can dwell and they can have their more questions, and we will take in next session the remaining portion, and also the other questions whichever will come, I'll share it across with you, sir.
Very well. Okay. Thank you, Nitin. Thank you. Thank
Thanks
you,
a lot,
everybody.
sir, for taking out time, sir. Thank you, everyone.